thank you so much for inviting me to join you. It's a real privilege and a real honour. I would have liked to have been at your conference in person on the 11th of September. I can't be there. I'm going to be really transparent. It's actually my mum's 80th birthday on the 11th of September. And so I promised her a spa day, a very posh spa day. So I didn't feel that I could go back on that promise. But you will be pleased to know that I've got my colleague here, Tom Micklewright. So Tom is a doctor. He's also ORCHA's medical director, and he's going to join me in today's session because he will be there on the 11th of September while I'm hopefully having a lovely relax at a spa. But it's so lovely to meet you. I've already put my email in the chat. So if anybody wants to follow up afterwards, I'd love to learn more about the work that you're all doing. I'm really, really passionate about the space when we're talking about digital health. And just very, very briefly, Kevin, you gave me a very kind introduction with all the different things that I do. But basically, I still feel that I am clinical at the heart of all this. And my big passion is about helping patients to access healthcare in a timely way. That's always been my big passion and my big mission. And for me, what digital health does is it really enables us to do that from people's own pocket. I.e. using digital health on their own phones. And for me, what that means is that millions of people can have access to healthcare whenever they want it. And of course, when they're using these technologies, they're generating a lot of data. And this is that real big tsunami of data that's coming our way. Just to mention, so Kevin used the word app. We also use the word app, but when we talk about apps, I'm not just talking about apps on the app stores. I'm also talking about digital health and software at large. So web-based platforms, portals, anything that's a software technology. And what we're absolutely seeing at the moment is that there is quite often an app or a digital health technology associated with everything that we're deploying. So hardware technologies quite often have a software element to it. And the data that's within those software technologies, I believe, is the big tsunami, but the big opportunity when it comes to how we can really think about people and patients' healthcare going forward. So I'm going to talk to you for the first part of today's session, and then going to hand you to Tom, who will take you through the second half. And we're going to really try and basically help you think about the foundations to plan for this tsunami. Tom, if you can turn to the next slide, that'd be great. So what do we mean when we talk about this tsunami of data? Well, the first thing to say is so I wear a wearable. I wear a Withings watch, and of course it's tracking lots of bits of data about my health all the time. Now, if I wear my Withings watch when I go in to see a GP, in that 10-minute GP consultation, my device and the software associated with it will gather more data about my health than the NHS will currently ever hold on me, irrelevant of how complex and complicated my clinical needs become. And that's what I mean by the tsunami of data. This is massive quantums of information about patients and populations' health. Now, I also happen to live with type 1 diabetes, and I'm continuously using technology to monitor my blood glucose levels and manage my condition. Again, the information I have on my phone is massive. And so that's what we mean by the tsunami of data. Now, of course, what we've got currently in our systems are a big infrastructure which is predominantly around electronic health records, which hold clinical data. So when I have a touch point with my healthcare providers, it holds information about those touch points, but it's not able to yet hold data about my health on an ongoing basis. And of course, if we think about where we want to get to, by using data, we really want to think about how we can risk stratify populations, prevent crisis, and target people who need interventions sooner rather than bringing everybody in because they live with a certain condition. And I am case in point. So I have to go to my doctors fairly regularly for diabetic checks, to provide information, normally verbal, that I could probably give via a data transfer if I could. But of course, our infrastructure is not yet able to cope with that tsunami of data. Now, I think what's going to happen, and a lot of people are now working on this, is we're going to see technologies and middlewares that are going to gather that information and be able to make sense of it so that we as clinicians or system leaders can utilise that health data, that tsunami of data, to really start to think about risk stratification and really start to think about how we can proactively manage that data to benefit healthcare services. So that's what we're talking about here. And of course, if you go to the next slide, the first step is we have to prepare for that tsunami and plan for it, because once those platforms are established, and by the way, ORCHA is not going to be that platform. But I want to talk to you about how we can plan for that tsunami, because it will happen and it's going to happen fast. And of course, what we want to do as providers of healthcare is manage that in a safe way. So the first thing to say is, well, how close is this tsunami of data? How real is it? Well, you can start to see here some high-level statistics about what our populations are already doing when it comes to digital health technologies and using software technologies, and the amount of people who are now gathering data on their own devices. So you can see there that simply every single day, 5 million people will download a health app or a digital health technology. Now, that's a global figure, but you can see here in the UK, we are the 6th highest user of these technologies. So our populations are actively going out, downloading technologies to either support them, like me, from a long-term condition perspective. There's a lot of people going actively buying these technologies in women's health and mental health, as you can imagine. So people are proactively going and downloading these technologies and using them and starting to build up some of this data in their own device. Just on that device front, we have billions of devices on the planet, and I'm sure that many of you on this call today have 2 devices. Quite often people have one for home and one for work, and what that means is we now have more smartphones on the planet than we have toilets or toothbrushes. And so what that tells us is that, again, we as end users are investing in this infrastructure. So people have a smartphone. It's really interesting how the world has changed so quickly, and I reflect on my parents, who I've just told you the age of my mum. My dad's a little bit older, and they've said themselves that having a smartphone device is as important as having running water, and they're in their 80s. So it's something that people just see as part of what they need. What we also know is that age is no longer the barrier it once was to our populations using these technologies. Researchers find that over 65%, and this is in this country, of people aged 65 and above want to use digital health. And the most recent Ofcom report showed that people aged 65 and above were the highest users from a time invested every day of the smartphone device, because they are retired and so they have time to look at their phone. And so some of these myths and concerns about whether technology would be adopted by our citizens and patients is really starting to break down. What we also know is that clinicians and frontline healthcare professionals want to use these. And of course, the NHS long-term plan has come out today. I know that the how it's going to be delivered hasn't yet come out, but I'm quite sure that the how will include patient-facing digital health technologies, AI technologies to support people to either better manage or to help themselves while they're waiting or wanting to manage their long-term condition. So the opportunity is massive. If you go to the next slide. So the scale and the nature of this tsunami is massive. And currently, as of today, we have over 350,000 technologies available. And they span everything from fitness to sleep, mental health, chronic disease, remote monitoring. And basically what that means is that real-time, real-world insights are possible. But only if we're ready for this tsunami, otherwise we're just going to get washed away with it. Now, it could, as I mentioned, really help to transform the way in which we prevent crisis and help with population health management to reduce demand on the system. And the reason we've got to get ready is for this problem. This is the big problem. So every day people are downloading these technologies and only 20% of those 350,000 plus technologies available meet quality criteria. Now, what that means, and I'll come on to what I mean by quality criteria in a minute, because it's really important that we understand that, is that the data inside those products and on people's phones is basically useless unless we can feel confident that the product is clinically valid, that the product is being used right, that the data inside is therefore useful, secure, and data private. These are really important elements. And of course, interoperates within our own environments. So 20% of people every day, that 5 million number, only 20% are finding something safe and effective and useful. And what that means is this tsunami of information is not going to be a very good tsunami. It's going to be full of non-useful information, which will completely muddy that water. So what do we do about it? Well, we have to build trust and transparency, and we have to help bridge the trust and transparency for our populations, patients and citizens so that they know what choice to make. And I'm sure that many of you are familiar with what a lot of countries are doing in this space, particularly what's happening in the NHS. But basically what's happening is that globally, different countries are looking at what good looks like. If we're going to trust these technologies and the data within them, what does good look like for this country? And therefore, if a product meets this criteria, we can trust it and use it. And we've seen a lot of digital health assessment frameworks, which is that criteria, be developed. So I've highlighted 9 here, but there are actually 120 digital health assessment frameworks globally at the moment. A lot of them are inactive, so a standard's been built and then it's been shelved, but quite a lot of them are active. So of course, here in the NHS, we have the NHS DTAC. Now, for anybody who's heard of the DTAC, and I'll detail what that is in a moment, it is currently being reviewed at the moment to see if it is fit for that future purpose, and being considered in line with things like AI, because when the NHS DTAC was created, AI wasn't really a thing. And so having a module within the DTAC which really fits that need is absolutely critical. Now, these digital health assessment frameworks, they all have a different name, but the questions and criteria that sits within them is in most instances the same to a certain percentage. So about 70% of all the questions that all of these digital health assessment frameworks globally are wanting to ask are the same. So I'm going to explain this matrix. So what this screen is trying to show you is the different digital health assessment frameworks which run vertically. So the first one is America, the second one's Europe, the third one's the NHS, the fourth one's Canada, and so on. And then running horizontally is where there is convergence and consistency of question sets. Now you can see that the pink section everybody wants to know the answers to the questions in that pink section. And what ORCHA have done is we've named that the Global Baseline Assessment. So we've spent a long time looking at all the different criteria in all these different frameworks, and we've pulled together where there is convergence, so where there is exactly the same questions being asked, and we've pulled that into the Global Baseline Review. The reason we've done that is because what we want to do is help other organisations get there faster to know if they can trust products, so that you can get on with deploying these products and utilising the benefit from them, rather than continuously all individually checking these technologies. So what we do is we run the Global Baseline Review. Sorry, if you can just go back 1 second. We run the Global Baseline Review to make sure that products have met that underpinning requirement. And then we say to a supplier, okay, which market do you now want to go into? So if you want to go into the NHS, we're now asking those next 4 buckets of questions. Now, what's really interesting, and probably the people who created the NHS DTAC don't know this in completion, a lot of different countries are copying the NHS DTAC because it was one of the first pioneering digital health assessment frameworks. And that's why you see America, Europe, Canada, Germany. You can see there's again a lot of convergence in that dark blue section, particularly around things like technical stability. But what's really interesting is when you look at clinical safety, so the DCB 0129, that's also been adopted pan-Europe, in Germany, and interestingly in New Zealand, because they looked at that criteria and said, they're good questions to ask. We want to know the answer to. Now, what this means, a system that ORCHA used to assess products, we can now passport compliance data from one jurisdiction to another and basically help different countries know if a product is safe or not very, very quickly. Now, you can see on here that interoperability is a line that is currently missing from everybody apart from the Nordic nations. Now, the reason I'm highlighting that one is because we really need to think about what interoperability means and how we plug this data in to our systems, electronic health records, for example, or middleware technologies, for example. Now, the reason the Nordic nations have got that nailed is because they started with a vision to have interoperability across an ecosystem of digital health technologies and to create a data lake for free movement of data across the 5 Nordic nations. And that was their starting point. That was their vision. And so they had to put it in to the requirements up front. And I think that that's what we're going to start to see in areas like the DTAC, where we start to say, okay, how do we plug and play safe, effective, clinically valid technologies into our infrastructure to really benefit from the data? So if we go on to the next slide, what I'm going to do is I'm going to talk you through what these different questions are that you need to think about and consider if you really want to engage in these technologies. So that global baseline review that I mentioned, these are the questions that everybody on the planet wants to know the answer to. And it covers things like data and privacy. So you can see there some of the standards that people want to know about. So this is things like GDPR or HIPAA in America, very similar. Things in privacy policies, data use, data storage, and other standards like ISO 27001, 9001, etc. Professional and clinical assurance is absolutely critical, because if you've got a product that says it can help you manage your COPD or monitor your COPD, but the data it's taking isn't right, and it's not valid, then there's no point in using that data in this tsunami. That's the data that's going to get very, very muddy. And of course, we want to make sure that these products are safe from a medical device perspective. So checking that a product has its medical device status and the right level, plus has evidence of impact. And then, of course, usability and accessibility is a really important part of this underpinning requirement. If you go on to the next slide, you can now see a little bit more detail about what sits on top of that for NHS DTAC. So these are the additional things, and I'm sure that these will feel very, very familiar to you. So you can see that there is a touch point from an interoperability and a SOC 2 perspective, but actually going into truly interoperating and getting the data out of these things at scale is a slightly different question than just having a basic connection with an electronic health record. Of course, clinical safety, DCB 0129 is critical, DPIAs, penetration testing and cyber essentials. So those are the things that you need to check over and above. And of course, the areas around technical assurance are really important, because otherwise we start to see in the press that there's been data breaches, and unfortunately we've seen some of those recently, haven't we, in the press, with NHS England pushing out notes about what to use or what not to use. Okay, so if we're going to the next slide. So why have I given you all that information? So this is about managing risks in this future data opportunity, but you have to have governance. Everybody who's ever worked in the NHS has that drilled into them right from day one. And what we're trying to do here is avoid chaos and embrace innovation. And it's about trust and safety, which of course is non-negotiable. And just to mention, one of the things what I didn't want to do was leave you hanging without saying, oh, and there is something that can help you. So on the next slide, very, very quickly, to say that there is a product called ORCHA Compare, which is a comparison site which helps NHS leaders to be able to view and compare what's out there and know whether a product is, or importantly, is not compliant with those requirements I just mentioned. And I'm quite sure that many of you have suppliers coming to you with their products saying this product can help you, and we could interoperate and we could share the data back into the healthcare system. And you just very quickly need to know yes or no, I want a conversation. Well, in here is the good, the bad and the ugly. So you can very quickly say, okay, you've not met this part of the requirement, so come back when you have. Meant to speed up that process. I'm not here though to really talk about the products and solutions that ORCHA have, but I wanted to mention that to you. So if you just go on to the next slide, and then I am handing over to Tom.
Thank you very much, Liz. Thank you for that. So what Liz has really articulated well there is how we need to make sure that the products that we're working with are to be trusted. So we know we're not drowning in all this noise, this data noise, when that data tsunami hits us from patient-facing and consumer digital health. But the second stage, really, once you've identified what's to be trusted, is how do we embed those technologies in a natural way into normal clinical workflows? How do we make it as embedded as pharmaceuticals, as medication, so it's as easy for a clinician to talk about digital health or recommend a trusted tool as it is for them to prescribe an antidepressant or an antibiotic? And the first thing I want to say as part of that is, historically, it's in kind of the procurement and commissioning space, our approach to buying digital solutions has always been to focus on single point solutions. It's been about identifying what is the best app for managing diabetes, or we've got a problem with elective care waiting lists. What one solution can we go out and buy to address this? But that approach, that paradigm, is completely at odds with the way we think about medications, for instance. We're so far beyond recommending one diabetic drug. We're just going to give insulin to everyone and kind of hope for the best. Instead, the conversation is usually about, well, how well controlled is that person's diabetes? What other medication are they taking? Do they have other comorbidities like obesity or heart failure? Are they at risk of hypos, kind of a low blood sugar, in which case we need to offer something else? And in kind of going through all of those, we can educate our clinicians to recommend a product that's personalized to the patient and actually addresses their needs at the time, rather than just a generic medication that may work for some people and work less well for others. And in digital health, it's the same. There isn't one best diabetic solution. There might be one best diabetic solution for a particular patient with a particular problem, and starting to match products to patient need rather than condition area, I think is the best way to start embedding these tools more naturally into our workflows. And when we start embedding trusted digital tools into pathways of care, I think that sets us up exceptionally well to make sure we're harnessing the right data in the future from those products. So to give you an example of how this might work, if you imagine a male patient with COPD, you might look at their entire care journey, the care pathway throughout a lifetime with that illness, and they'll have different needs at different points in that journey. Imagine you're seeing a COPD patient, one of your clinicians is in a kind of an annual review type setting. So they're stable, they've not had an exacerbation. Then you might be able to put some things in place to help lower their risk of problems in the future. You might offer them smoking cessation tools if they're still smoking. If you notice their medication compliance is poor, perhaps medication reminding tools might be helpful. Or if they live in a very industrialized area and you notice that pollution and air quality is a common trigger for their COPD, there are tools that can help with environmental monitoring too. At the point that they come in and see someone with an exacerbation of their COPD, again, there are different tools you might recommend based on the problem. You might offer them a remote monitoring or a virtual ward type tool to try and manage them out in the community. You might offer them a tool to help educate them about what's happening with their exacerbation, why they're having a flare-up, and why taking that course of steroids and antibiotics is really important. Or a symptom tracking tool so they can monitor how they're progressing and they know when to come back to see your clinicians for help if they're deteriorating. And then on the other side of that, they've just got better. Well, perhaps there are opportunities there to improve their inhaler technique through technologies, or perhaps even offer pulmonary rehabilitation that they can do directly from home rather than having to travel to a specialist center where we know adherence to treatment is pretty low. To give you just one more example, let's have a look at an elective care pathway. So imagine a woman in her 70s has been referred in for a hip replacement. Instead of thinking, right, what is one digital solution, the best digital solution for hip replacements, we can start thinking, what are the different needs that patient has, the different opportunities for us to intervene, and the best products for each of those opportunities. So whether that's getting that lady fit for surgery so that she has a lower risk of complications, a reduced length of stay, and trying to manage her comorbidities, her weight, her smoking, you can do all those things through technology. Once that patient passes through the pre-op pathway, there are technologies that can help with pre-op efficiency, so most of that's done remotely. And then at discharge, again, there are tools that can help with rehabilitation or coordinating formal or informal carer support. So it's moving away from let's choose one solution for a huge population group. And if we're really going to start embedding these technologies that can bring with them a wealth of data, we've got to start thinking in terms of care pathways and embedding them at multiple steps along that pathway. This is a real life example of a depression care pathway that we developed with one of our NHS clients. And you can see here, for example, what we've tried to do is match particular trusted assessed products to patient preference. So whether a patient prefers audio-based CBT, whether you think they'd be suitable for behavioral activation or perhaps mindfulness-based CBT, you can be confident recommending particular tools based on that preference. Or if a patient's attending in crisis, again, tools that might help with self-harm management, suicide prevention, or acute stress. But having it laid out like this means that we're getting personalized about embedding digital health into routine practice. The final step that I want to talk about, and this is really what I think is the holy grail in terms of adoption, is making sure that we're implementing and deploying digital health in a way that is independent of clinician time. I feel like I can say this because I'm a clinician, I'm a GP, but I think sometimes one of the barriers, a significant barrier to digital health adoption, is a very, very busy clinical workforce. And when we're busy and we're stressed and we have no time, we fall back on trusted routines that we've developed over our professional lives. And trying to change those trusted routines and trying to change them to adopt some of these new paradigms of how we can be delivering care is exceptionally difficult. And you only need to look at the life sciences industry, who pump billions of pounds into trying to change clinicians from prescribing one drug to another to see how big a challenge that is. But if we can automate some of this, if we can start trying to match patients to valuable, trusted digital tools without them needing to go through a healthcare professional first, I think we can massively increase the use and adoption of these tools in routine healthcare. And this isn't just theory, by the way. This is hitting us right now. ORCHA have recently launched a product called CareQ, which does exactly this for the elective care population. So at the point of someone being referred in for, let's say, a hip operation again, or maybe another kind of surgical procedure, we're already generating structured, coded data for the referral and the specialty the patient's gone into. The patient will also have structured coded information related to their comorbidities, whether they're overweight, a smoker, poor diabetic control, or other things that might increase their risk of surgical complications. And when we bring that data together, we're able to set up a sequence of rules that lead to an automated recommendation of trusted tools that can help that patient. So the clinicians are involved in setting up the rules and designing the system, but then they're able to let it run without consuming more of that busy clinical resource. And this is kind of how it works on our system. Our system is just an example of how it can run. Patients receiving an automated text message explaining, we know you've been referred onto a particular pathway, a particular elective care waiting list. Do you still need the appointment? So we're validating whether there's still a need for the patient to be on that waiting list. And if there is, then we're then able to make personalized recommendations of products and tools that can help, tools that are trusted, and then getting them embedded in the healthcare ecosystem. We're just at the start of this journey, but already we're seeing massive benefits. And we believe we're impacting up to about 30% of the waiting list population at the moment. Not just validating whether they need the operation in the first place, but better matching resource to need and optimizing patients for their procedures so they're less likely to have complications, they get out of hospital quicker, and they have a much speedier recovery at the end. Having done that work in elective care, we're now wondering whether we can do the same in general practice as well. CareNav, which is our kind of PCN general practice product. It consists of a health app library of trusted digital tools that receptionists or care navigators can signpost patients to. It's an e-prescribing type formulary, so the clinicians can prescribe digital tools straight from their electronic health record. But over the next 6 to 9 months, we'll also have the ability to set up automated rules-based systems as well, so that we're able to identify when a patient has, for instance, had a new diagnosis of depression or been referred for talking therapies, and automatically follow up with 2 or 3 trusted digital tools that they can start engaging with straight after their consultation. Now, when we look across our international neighbours, we can see that this idea of putting in frameworks, building trusted libraries and formularies of tools and building systems around them is starting to become the new way forward. Germany's had the DIGA for a while, which is started off as a bit like DTAC, an assessment criteria, but turned into a full reimbursement model so that as clinicians, they can take digital products off of the shelf, recommend them to patients, and then a reimbursement will follow in the same way that medications do. In Canada, the Mental Health Commission of Canada have developed their own repository of trusted assessed mental health products that clinicians can recommend to patients and that patients can go and access independently. And there are a number of partner organizations that ORCHA work with to do exactly the same. So it's not about saying, don't do this, stop doing this, and stifling innovation. It's about saying, let's embed these safe, trusted tools so that when we're in the position to draw through all that patient-generated data, we know we're doing from a solid foundation. So in summary, I think the most important thing for all of us as healthcare leaders to bear in mind is to prepare for this tsunami of healthcare data and prepare for that point where the middleware exists for taking that data and generating insights. There are some core steps we can be taking now. Firstly, we need to make sure that we're choosing the technologies to work with that are safe and effective, and we have to have a robust framework for assessing them in order to do that. The second thing is, once we know what's safe and effective, let's embed them now. Let's get them straight into digital care pathways, embed them at multiple steps of care so that clinicians are familiar and used to working with these technologies and trust them when the time comes to lean on them for their data assets. I think we can start supporting clinicians by looking at systems that make it easy to deploy these tools, whether it's digital health, e-prescribing, health app libraries, or automation tools. But I think whatever the future looks like, we need to design it with clinicians and stress that this is about preparing for a very exciting future where we can harness the power of not just empowering patients to self-manage and become more active in their health, but where we can also draw on all of that rich data to make the best use of those insights. That brings me to the end of our presentation. You've got mine and Liz's email address there, and we would welcome anyone to reach out, contact us